and another x-ray in 2 more weeks, and waiting for a good report. We're going to begin with any introductions of requests for introductions of bills.
Thank you, Madam Chairman. Good to have you back.
Thank you.
I represent the ADSO, the Association of Dental Support Organizations, and together with the Kansas Dental Association, we have a bill that we want to present. It's 23 RS 0219, dealing with the Dental Practice Act.
Thank you.
Stand for
any questions? Yes.
Mike, could you expand a little bit on what's
Certainly. From the Kansas Dental Association's standpoint, they have some language they want added that would provide a little bit more patient transparency in terms of who the treating dentist is, license number, some details about that. And then from our standpoint, elimination of what is a very, very old law that limits the number of offices that any particular dentist may own. It's called the 20% rule, and we are seeking repeal of that, and we've worked that out with the Dental Association.
Any other questions? Thank you very much. We're going to begin this morning. First of all, I want to say I was caught up. I don't know how many of you come in from Kansas City, but on I-70, it's backed way up due to a wreck, I believe. And so we have a couple of our people that'll be on WebEx this morning along with us. But we're going to start with Dennis Kriesel, and he'll be giving us the overview for the local health departments in Kansas. Welcome to committee, Dennis.
I was not on. The light wasn't on. That might have been a hint, but, and I know they're working to get up the slides onto the screen here for y'all. All right. Thank you very much. So if you want to go ahead and advance to the next slide, let me just start with what my association is. So I'm the executive director of the Kansas Association of Local Health Departments. We are a 501c3 nonprofit. We consist of a whole 2 staff members, both full-time, myself and my assistant director. And membership in the association is voluntary. So there are 100 local health departments in Kansas that represent all 105 counties. They choose whether or not they want to be members and called. Currently, we do have all 100 members in the association. And our main functions as an organization are a liaison between Kansas Department of Health and Environment, or KDHE, and the locals. That's probably what I spend most of my time doing. Providing technical assistance. We supply certain resource guides, manuals, and such, along with education. We have one mid-year meeting we do every June in particular that's very education-focused for health department administrators in particular. I communicate with the legislature, so that's one of my roles. And then we also facilitate a lot of communication between local health departments for peer-to-peer learning. We host a number of listservs where they can share things like job descriptions, how do you handle WIC in your county, how maybe we could learn something to do it a little bit better in ours, those sort of discussions. So that's a lot of what the organization itself does. Next slide, please. So let me go into what the actual health departments are, or what they look like. So Kansas is a decentralized public health state. The majority of states in the United States are either decentralized or primarily decentralized. And all that really means is that most of the responsibility for public health falls on the local level. And in the case of Kansas, that's organized around county government. So as I noted, we have 100 health departments in Kansas, and the reason for that is we do actually have a couple of consolidated departments. But what you can see on this slide is a breakdown as best as I know it. There's not a good universal reporting on all of these, so if there are discrepancies, they're my fault and I apologize. But so organizationally, 86 of the counties operate their health departments in what I think most of you would think of as the traditional county departmental way. You know, we have a road and bridge, we have our noxious weed, we have our sheriff's department, we have a local health department, and it just runs under that rubric. But the rest do something a little bit different. So as I mentioned, we do have a couple of multi-county health departments. One is in the Northeast, NEK, for Northeast Kansas Multi-County Health Department, and then SEK, Southeast Kansas Multi-County Health Department. And you can see those counties listed in the parentheticals on the slide. There is a statute that allows for that sort of regionalized consolidation to happen, and so that's what occurred to form those two. Both of those multi-county health departments do have office space in all of their member counties in order to be able to provide clinical services. In addition, another statutory provision is to allow populations under 15,000 to use a hospital to run their health department for them, so there are currently 4 counties that do that. EMS-led is vague. It's more, think of it more EMS combined. There are some counties that have indicated they've sort of merged a couple of departments. EMS, Emergency Medical Services, has been the case sometimes with health departments to get them together so that both departments are under one. Counties do this a lot also with road and bridge and noxious weed. Sometimes they'll merge that as a public works department. So think of that as a merged department, but it's pretty much the traditional model otherwise. And then finally, there's actually, because county commissioners can use contract authority to enter into contracts for public health purposes, there is an instance in Lyon County where they contract with a federally qualified health center to provide the health department services for their county. So that's the overall structure of how we see the decentralized makeup in Kansas. Next slide, please. And so, money. We'll go ahead and talk about what does the funding system look like. If I throw all my slides, that's okay. I only vaguely need that one. It's like, my most important one. All right, so this is self-reported data from the local health departments. Every year they fill out something, we call it the state formula survey, because there are some state formula dollars that the state allocates to local health departments. In order to get that, KDHE requires them to do a survey. My association participates in crafting that survey. It's a slew of questions that teach us a lot about what the makeup of local public health is in the state on a year-by-year basis. This pie does not include COVID money. So they were asked to report their COVID dollars, but to report them separately. So this should be what we kind of think of as a typical allocation of funding, because the COVID monies were very one-time and oriented around the pandemic. So the overall reported amount here is approximately $133 million total. As you can see, the largest slice, I won't go over every slice, but the largest slice of the pie is the one that says local, city, county, which again, being decentralized is not particularly surprising since most of the authority rests at the local level. There's a large demand that they fund public health. So they fund a little over a third of it. The second largest slice of the pie is federal funds that don't go through what we call ATL, or aid to local. And aid to local is just a way that local health departments go in and apply for grants through KDHE. They have an aid to local package of grants, which is the third largest slice of that pie, 16%. Now, most of that money is actually federal. ATL consists of federal programs, and it does also consist of dollars that the legislature has allocated to particular programs. And that's actually, I should say, that's the fourth largest pie. It sometimes oscillates with fees for service. And in this year that we're looking at, which was state fiscal year 2021, fees were 2% higher. And that's charging insurance, basically, and out-of-pocket pay. So if you go to the next slide, we'll actually go a little bit into the breakdown on what these slides consist of, or slices, I should say, in the slides. All right, there we go. So federal funding. So again, COVID dollars aside, some of the notable funding streams that we see from the feds are these that I've listed here. So FEP is Public Health Emergency Preparedness. Family Planning, you might know that as Title 10. There's MCH, which I believe is Title 5. There's HIV prevention money. There's WIC, which is the Special Supplemental Nutrition Program for Women's, Infants, and Children. And then VFC, or the Vaccines for Children program. I'd say those are the main ones that people are familiar with that consist of the bulk of the dollars that we see from the feds. And a lot of this is in that ATL package. And so The main thing I think is a takeaway just to note when understanding health departments is, as you can probably tell from the list, these are very categorical streams. So if you have VFC money, it's to be used for vaccines for children. You can't use it for adults. You can't use it for a non-vaccine purpose. MCH is for MCH. That's how the feds often like to do it. Next slide, please. So state funding is a little bit different because there's a lot less state money involved in local public health specifically, but what is available is often a lot broader in terms of its ability for the health departments to use. So our main allocation that the health departments see is what I refer to as the state formula. That actually is defined in statute, that's 65-242 that handles that. This is a formula that until recently, as of 1992, allocated $2.2 million statewide for local health departments with a minimum of $7,000 per department. Now, the way that statute is actually phrased is you either get the minimum or you can get a population allocation. And 2/3 of the health departments are in counties that have a population size too small to get more than the minimum. So roughly 2/3 had been getting $7,000 a year in state formula. Now, for the last 3 fiscal years, the legislature has actually provided a proviso in the budget to raise that minimum from $7,000 to $12,000. And just as an FYI, when the budget process goes, I know that doesn't go through this committee, but just to make you aware, we will be asking for that proviso to continue because we are trying to update 65-242 to no longer lock in that $7,000. That request actually is being considered by the House. I'm expecting a social service budget or appropriations to probably introduce that, and we're asking to move that to 12 like the proviso, but also eliminate the minimum and change it to a base plus population so that everyone sees an increase if the legislature chooses to allocate more funds to support local health without having to always go back to the statute for 2/3 of them. So. But this funding overall currently is now $4 million. We've received increases from the legislature in the budget process for the last 2 fiscal years. We're still trying to catch that up for inflation and population changes, and that's all we as an organization have been asking for. That would be another $1.4 million, though, given what inflation has been as of last summer when I last calculated the math. So. Again, this is funding, though, that can be used for essentially any local health department purpose. So they use it for a lot of things that they don't have that federal support and enhance what their local departments are getting from their local governments. This statute does have provisions requiring local match, essentially. So the state formula, they cannot get more than what their county kicks in. So if their county doesn't kick in $7,000 in property tax support, for example, they don't get $7,000. They get no more than whatever the county kicks in. And also, if there are any county reductions in support, the same percentage is reduced out of the state formula for that year. So if a county says, I'm going to lower the property contribution by 10% because my population is getting smaller, the state formula that year will also go down by 10%. Next slide, please. So that was the state. And so local, I've already touched on that a little bit. Property taxes is the vast majority of this. There are from time to time counties that do allocate a portion of the sales tax to supporting the local health department, but it's pretty rare. Most of the time, if there's anything health related that I've seen involving sales tax, it's usually to support a hospital. As I did have on the prior slide, we do actually have 2 city-county health departments. That is another statutorily allowable kind of consolidation. And so there are city tax dollars that do go to those 2. Lawrence Douglas County Public Health is a city county, and then City Cali Health Department in Cali County is a city county. So they do see some city dollars. Back when I actually started my career, which was actually with the Kansas Association of Counties, I think in the early 2000s, we had 6 or 7 city counties, but it seems every recession, a city decides, I mean, there's no statutory requirement that they do it, so it becomes a tax liability that maybe you don't want anymore. So we've seen that dwindle over time, but there are still 2 that stand. Next slide. So fee-for-service, this is very straightforward. There are a lot of clinical services that health departments provide, and they can bill for a number of those. Some of those are billed on a sliding scale. Sometimes there are individuals that come in, like for indigent care, where they do not pay at all, and then sometimes they accept insurance, and they'll take insurance payments. So fee-for-service is actually a sizable slice. In some counties, it's actually very substantive, more than their tax support level, that they're very fee-reliant. But, of course, the main sources of there would be direct out-of-pocket, private insurance, and then Medicaid or CAN care. And next slide. So one of the items I was asked to discuss with you all today is services that health departments do. So health departments as departments are very service driven. I know during the pandemic there were a lot of discussions about, health orders and stuff. And ordering authority is really more that's stuff that health officers do, Secretary of KDHE does. Health departments are the staff that implement whatever the will is of the governing bodies that they work for. So a lot of that is service provision. This is not comprehensive. These are 20 that I chose out of a list, and we have good numbers out of the state formula survey if we want to discuss services. But in fact, those numbers in the parentheses that you see in bold, those are the number of health departments that as of that fiscal year 2021 state formula survey said they do this direct. Now, some of these services are provided by contract that the health department contracts with another entity in the county. There are numbers on that from the formula survey as well that we could pull. There are also instances where a health department will contract with a neighboring health department. So the departments are not consolidated, but they will work together as a team, sort of like a regionalized WIC program, for example. So those are not included on this slide. And then in addition, there might be instances where a service is provided, say, private sector, that there's no need for a contract for because the private sector is already providing it in the county. So you can see this runs the gamut. Again, this is out of 100, not out of 105 because of the 2 consolidated health departments. But you'll see very, very strong levels like immunizations, for example. There's a statute that requires health departments. And the way they define health departments is actually a local board of health in that statute. But there's a requirement that children that want to receive immunizations that are on the childhood schedule have to have a place that they can go where they don't have to pay. So normally that's actually done at the departmental level. If it's not, it's contracted to another entity in those 2 instances where it's not, for example. NEMAHA is one of those, and they just recently brought their health department in-house as a regular department. It used to be with the hospital. They're still having a hospital provide the immunization services as they staff up, as a case example. And then this already, as you can see, dwindles all the way down to very, very low counts on some things like home health services. There are still some counties where there's no other home health provider, and the health department chooses to do it. So there are 15 health departments that are still actively engaged in that sort of work. Mental health first aid, so sort of crisis mental health training has happened at some of the health departments, and you can see on the slide there are 17 that engage in that sort of thing. Like car seat installation, sometimes the health departments teach people how to properly use car seats. Sometimes it's done somewhere else, like I know fire departments do that in some counties. It's done in about half of the health departments. So anyway, that's just sort of a litany of common services that we see to varying degrees in the various counties. And next slide. So that's it. That's my quick and dirty summary of local health departments, and I'll be happy to stand for questions.
Thank you so much. And committee, do we have questions? Yes, Senator Petty.
Thank you. Dennis, thanks so much for being here. I was, it seems like our health departments, we just assume they're there, kind of like libraries, that they're going to be there for services for someone. And when you mentioned about, as on the slide with the services, and you mentioned about mental health, even though we now have 988 and we have, and some of our counties have mental health centers, do our health departments find that often people will call them first when they're looking for some sort of mental health assistance?
Thank you, Madam Chair. I've not heard so much about calling in. The bigger issue has been when people come into the clinic and they're presenting signs that they're suffering from some sort of mental illness, and the health department doesn't always know exactly what to do with that individual who's in crisis. So again, and this is more anecdotally speaking, but asking health departments, because we do collaborate a lot with the Association of Community Mental Health Centers of Kansas, for example. We're participating in a project with them and the Community Care Network of Kansas right now, actually, regarding that whole transition to CCBHC from CMHC. And one of the things I've asked health departments is, so what's your relationship like with your community mental health center? Because there are far fewer of them, because they represent a lot broader regions by and large than health departments, which are essentially in every county. And generally speaking, it seems to be the further you are away physically, the harder it is to have a solid relationship with that mental health provider. And again, on the surface of it all makes sense. If an individual's having an issue and you need to get them to the mental health center, can they get there? or do we have to wait to services to get to them? And that's where things like mental health first aid have become something that the Association of Community Mental Health Centers has been willing to provide training on to local health departments. The MCOs have also reached out and said, you know, we do mental health first aid training. We would be willing to try and educate and get more people familiar with that, so that when that person comes in, you can basically triage it and try and get them stable. Excuse me. Apologies about that. Rogue dust bunny. And get them stabilized, and so then they can actually go for something longer term to actually get them into a good place. But mental health is not a strong suit of the local health departments, so it's, and we've seen so much turnover, you know, across healthcare really during the pandemic years and such. So a lot of the people that got the training, if they were like, well, I can make more as a traveling nurse, I'm going to go be a traveling nurse, well, that brain drain has happened out of the local health department, and we have new people now, and we need to get them educated on this. So the good news is, as of really last year in particular, things have started to get back to, I'm going to air quote it, back to normal, as we call it in public health, where we're doing non-pandemic stuff. We're doing these outreach things. We're doing health promotion. We're dealing with chronic disease. And so there's a lot of demand now for more of these trainings on mental health, trainings on how to do Can Be Healthy, screenings for kids, stuff that just wasn't getting done during 2020 and 2021.
Thank you. Can I? So, and when I'm looking at the list of services that you had here, and when you showed us the pie of funding, I'm going to make an assumption that the majority of these services are specifically funded, a lot of them through federal funds. Would that be correct?
Yes. So, for example, like immunization services, a lot of that's going to be VFC dollars, Vaccines for Children program money that comes in. I think the state has a little bit of vaccine money they also throw in. So those are like grant-driven specific sort of options that you can engage in. Same sort of thing with like MCH services and WIC services. Those are federally sourced funds that are allocated through from KDHE. So yeah, a lot of these are individually, categorically funded projects. And that's been, in terms of a topic amongst local health departments, that's been a subject of, you know, we often talk about public health modernization. That's the dream, is what should a 21st century public health department be? What should every citizen be able to expect in terms of public health services, whether they live in a rural area or an urban area? The challenge, of course, is, well, where's all the money at, though? If there's money in immunizations and WIC and MCH, then that's what we're going to do, because there's money for it. If there's not money for health promotion, then health promotion is deprioritized because there's no funding source for it. In some instances where we can work funding, so like state formula funding and local tax dollar funding, that's more flexible than the feds. The feds are, as I noted, are very, very categorical. So that's where the state formula is one of the most loved funding streams, even at $4 million, that's a share of that $133 million pie, it's very small, but it's so flexible. Like, we don't need more money to do immunizations. We need money if we want to do a campaign because we need to do more diabetes education, or maybe we want to partner with the Mental Health Association and try and deal with teen suicide, things that we don't always have funding to do. So state formula gives us that flexibility, as does local support. And if they're making enough off of services, there could be fee-for-service income that could be then essentially repurposed, because once that money comes in, you can basically do what you want with it. But fees usually at health departments are pretty low. That's part of the reason why a lot of people will go to them in some counties as a lab draw provider of choice. There are individuals in some counties that go there, have insurance, but choose not to use it because the out-of-pocket cost is so much lower to just go to the health department anyway, rather than mess with the insurance company. So they'll just go because it's affordable.
And Madam Chair, I have other questions, but I'll let others go ahead and come back.
I'll be happy to come back.
Thanks.
Senator Erickson.
Thank you, Madam Chair. Thank you, Dennis, for being here. Just a quick question. You touched on it briefly in your response to Senator Petty, and I apologize if you covered it in your slide. I didn't see it, but overwhelmingly we hear of the workforce shortage. I assume that you are no different, being in healthcare, and that there's such a need for nurses and qualified medical staff. So can you tell me the extent of the issue of workforce shortages that you're hearing, and what's being done to address it for the health departments?
Sure, and thank you, Madam Chair. No, I didn't touch on it in the slide, so definitely something to go into. There are numbers that KDHE could probably pull out of the state formula survey to give us a better sense of where things stand in terms of employment. But from what I've heard in my discussions with the membership of the health departments is RNs in particular are a big issue at this point. Actually, approximately a year ago, I started getting a lot of questions from health departments about just what can we do with LPNs, because we're finding them easier. So what are our options? And in fact, one of the resource guides that I mentioned that we're working on, that we're hoping to have finished up at the end of the month, we actually have KDHE reviewing it right now, is a resource guide that sort of breaks down, here's what an APRN can do, here's what an RN, an LPN, a CNA, and sort of like matrix it on a table. It's just like, here are common health department services, here's who can do them, or can't do them, or can do them with supervision. And we're not pursuing, say, any legislation at this time to make modifications to, say, expand LPN authority. Those discussions have been things that people have asked about amongst the health departments, like what could we do to allow other people with other levels of licensure than registered nurse? Because so many of our services are reliant on at least a registered nurse, and physicians rarely work for health departments. Most health officers who are physicians are contracted. They don't actually work at the health department. They have a day job being a doctor somewhere. So sometimes there are doctors who will come in on occasion, be it volunteer or contract, to do certain medical services through the clinics. But employing doctors is very rare for health departments. So usually the RN is the highest level medical professional that we have at our disposal. And as you've noted, it is incredibly hard to keep them. It used to, because we pay so little compared to hospitals, and now even the hospitals are struggling because of the traveling nurse fees. Of course, those are mitigating now that there's less demand for the traveling nurses. And that's always been the case. It's just the argument I've been told is in the good old days, pre-pandemic, in the good old days, the thing about the health department that was appealing to some nurses was the stability of the schedule. You knew you had 40 hours a week, and that was it. And then disease investigation took over their lives, and they worked 60 to 80 hours a week, and they're like, well, why would I do this if I could make $20 more an hour somewhere else? So, again, now that we're getting back to normal, we're hoping some of that will mitigate away, but if the salaries don't come down in the other locations, ours would probably have to go up in order to attract those level of individuals. The only other alternative is to find other workforce individuals who are not RNs per se, but like LPNs, and see what we could do with that. And are there services that maybe we haven't been providing with LPNs that we could start doing? But those are the discussions we've been having internally with the membership.
Thank you. Other questions, committee? I have a couple. Thank you so much for being here. One is also regarding the funding that you were showing us. If we could go back to your slide of the pie chart. And in the gray, it says other state funds not included, and that's the 4 million. So would that be that 7,000 that's now become 12,000 that you were talking about? Does that fall into that category?
Thank you, Madam Chair. No, because that's other state funding not allocated through the aid to local grant, and state formula goes through the aid to local grant. So that's in the 16% pie slice that says total aid to local funds.
Okay.
I'm not entirely sure everything in the 4.5 million. An example, though, would be health departments that engage in environmental services. So environmental public health is public health, but at the local level, environmental's not often at the local health department. It's like in Johnson County Health and Environment, hence the name. But in a lot of counties, planning and zoning, for example, might house the environmental arm of the county to enforce, it's because a lot of it's related to codes. So it just depends, but certain funding just doesn't go through the ATL process. That's what that 4.5 million is. But I know the state formula is in the ATL.
And so if I'm looking at we'll call that a lighter color of blue, then, and it says total aid to local funds, that is from the state.
Yes, state and federal. I apologize.
That was going to be my next question then. Part of that you said is kind of a pass-through, that the federal dollars come to the state, and then the state pass those dollars on to the local government. Is that, or to the local department? Is that right?
Yes, and I believe in this formula of the 21.6 million, approximately 4.3 million is state supplied.
Okay.
And at this was still before we had any of the state formula increases. So 2.2 was that 7,000 formula, 65,242, and then the other 2 million was some other stuff that the state supplies through some of their other bureaus that go to health departments.
So in the prior formula of 2021, it was 7,000 per year. Is that per annual or what? 7,000 per what?
Yes, 7,000 per year,
Per year.
minimum for health departments, and it was a total allocation of 2.2 million. That minimum and that allocation of 2.2 was 1992 to 2021. Yeah, so this current fiscal year we're at 4 million, and we're operating under a $12,000 proviso. State fiscal year 2022, we were at 3.2 million operating under the $12,000 proviso. And then in state fiscal year 2021, the legislature approved an increase. The governor's allotment took it away, but there was still the proviso. So it was 2.2 million total with a proviso at 12,000 minimum rather than 7. So that just came out of the larger counties. It funded the smaller to get up to the 12.
And I'm assuming the 12,000 was because of COVID, correct? It says temporary. The 12,000 was initially temporary. I'm assuming it's because of COVID.
Actually, no. We had gone in that year before we knew COVID was coming. We'd gone in that legislative session as an association seeking the total amount of funding. And we had a bill drafted to increase permanently the minimum, and it was on the Senate side, actually. They saw that, and they were like, okay, well, COVID was now coming. We knew the session was going to get cut short, and they're like, let's put in a proviso because there ain't no way you're getting your bill this year. So they put in the proviso up to 12, and then every budget year since, it's been 12. So like we had a bill to raise that permanently from 7 to 15 in 2021. The House approved it, and then the Senate reduced that to 12 in their committee, and then it just sat below the line for a year and a half and didn't get a vote. So this year we're coming back asking just for 12 to hopefully satisfy them. And then also our membership at this point feels it would be more fair to just do a base plus population so that if you all decide as legislators to increase the state formula in the future, everyone would see a proportional share. Sedgwick, Wyandotte, Douglas, and Johnson are going to get, and Shawnee are going to get the most of it. But at least everyone would see something if there's an increase, because currently people are feeling like, well, what's the point if there's an increase and 2/3 of us don't get anything? So that's sort of where the 12 comes from. So it's been temporarily sustained, but the goal has been to try and make it permanent. And I think the relevant budget committees agree with that philosophy. I shouldn't speak for them, but I'm quasi doing it. That's been our read from them, is they've been supportive of that, but they understand it takes a statutory change to make it permanent. So that's why we're going to ask for the proviso again this year, because I don't know that my bill will get through.
I see. So then the base plus population, is the base 12?
Currently, the amount is 7 in statute, but it's not really the formula. If you were to read 65,242, it's extremely confusing. I had to read it 6 times, and I still misinterpreted the formula until I read it the 7th. It says you take all the health departments, you plug them in, their populations in, and you run however much money you've got allocated through the budget. So currently 4 million. Anyone who doesn't get $7,000 only gets 7. And the way it's written, it says you can't have more. You only get the 7. And then what happens is KDHE does that calculation, but because you ran the population the first time and not everyone was at 7, you've got to add everyone up to 7 that wasn't there. So then you have to recalculate, because now there were counties that got over $7,000 that don't get it anymore because you reduced your total in order to make the others whole. So you rerun the formula 3 or 4 times, and then eventually the math finally adds up. And so with the 12, it works the same way, except we go to 12 instead of 7. So yeah, it's about 67 health departments that get that 12. I mean, they're currently planning for the 7 because we don't have a proviso anymore. But 7 or 12, the difference between the counties that are at the minimum is like 2. It doesn't change much. We'd have to pour millions of dollars into the current formula for you to actually see people get past 7, and I don't think there's an appetite for that.
Thank you. You just described my confusion as I was looking through that funding in preparation for this meeting. Thank you very much. My next question is regarding the costs for services. Is there somewhere that we could see online? Is it different per county as to what costs or services are based upon the income in the individual that shows up at the county office?
Thank you, Madam Chair. I do believe it varies by county. There might be some programs that mandate certain levels, but I'm too ignorant of it to be able to speak with any authority on it.
Is there any way you can get me some information on that?
I will. Yeah, I'll put in a request. I'll talk with KDHE and see what we can do.
Thank you. And I have two more questions, but before I go on with my questions, anybody else on the, all right. Dr. Steffen.
Thank you. Do you have any idea what the total amount of money that the county health departments received from the COVID response was and how much remains unspent?
Thank you, Madam Chair. At this point, I can give you some of them. So we saw coronavirus supplemental funding. I think the local share on that was very small. It was about 1.8 million. Then, as part of CARES Act, there was ELC, epidemiology and laboratory capacity funding that was allocated mostly for staff to do disease investigation control. That was, I believe, 20 million that went local. That should all be, I think ELC has to be finished out by the end of June. So there might be some that are still, because there was an extension on ELC under ARPA. So they just added to that particular program. So they're allowed to spend through the end of that. Regular CARES Act funding that the counties got, I don't know what share ended up going to the local health departments. The deadline, though, to spend on that was the end of December 2020. Yeah, 2020. It got extended by by Congress, but by then Kansas had already spent it all because we didn't know it was going to get extended. There's still ARPA funding in play, but again, I only can find out the amounts that went to the counties. They report how much they gave to the health departments, and I'm not sure what those totals are because the U.S. Treasury in that instance allocated directly to the counties, which was different than CARES Act, which went through the Spark Committee. And then there is some workforce development funding that is not yet allocated, that is tied to ARPA, that's supposed to be spent over a 5-year period. Kansas just got the allocation. I don't know the exact amount for the locals, but I believe it will be approximately $10 million total. And that's all that's coming to my head on the COVID side, but I may be missing something, so grain of salt.
Senator Petty.
Thank you, Madam Chair. Dennis, this is back to the formula. So on the proviso and the 12, so you mentioned about having a bill right now in the House, but that's, is that to make the 12,000 minimum in plus population put that into statute?
Thank you, Madam Chair. Yes, that's what the bill, it's currently being drafted by right now. I've gone through House Social Service budget for that introduction. I don't know if it'll be introduced in appropriations or House Social Service budget, but I went to the chair for House Social Service budget on it. So it's not yet enrolled, or excuse me, not enrolled. It's not yet introduced. It's being drafted right now.
Okay, and then, so would that be that 1.4 million addition to cover that?
No, the 1.4 million, I come in when the relevant committees hear KDHE's health budget, then when they ask for public comment, because the governor's not the governor's never recommended an increase on health department. So I come into the legislature and I will ask the legislature's budget committee to please add more money. And the 1.4 is the amount I will be asking for.
To add to the 4.
To make it 5.4 million, yes.
Okay, and then, and so then that would be that if that addition was made, and then the other when we came to the changing from the 7,000 to the 12,000, that was your funding had not changed since '92. Is that correct?
Yes, that's correct. As near as I was in middle school, so I don't remember it, but that's what KDHE indicated as their records had shown. 1992 was the last change.
Right. I always think that's an important piece to remember because it's a long time for the amount of funding not to change. But the 5.4 then would cover the $12,000 base plus population.
Yes. The current amount of money could support 12,000 and then allocate off population as well. We have enough in the budget for it. But I should note that the current statute and the draft version to make these modifications does have a provision. It doesn't encumber the legislature to make sure there's always 12. It's all subject to the budget. If there's not enough to cover 12,000 per, then the money, if any, is allocated will just be equally divided amongst the health departments.
Plus population.
If we couldn't even get to the 12, then population's moot. It'll just be equally shared. Like, if there's only enough to give everyone $5,000 right now, the way the law is written and would remain written under my version is everyone just gets 5 and we're done with it.
But that's not what we're doing now.
No, because we were allocating 2.2 million, which even 2.2 million, if you were to go, it's nice because there are only 100 health departments. So $12,000 requires $1.2 million because there are 100 of them. So changing the base, doing a base versus the minimum isn't going to really shift any of that. It's just going to it's going to move the deck chairs around a little bit in terms of some of the larger departments that currently have been benefiting from this provision in the current law that says if you have this amount of population and can't get up to the minimum, you only get the minimum, you can't have anything more. If it's going to be proportionally shared off of population after that first 12,000, then some of the larger ones will fall down a little bit. The amount that we would need to not see them fall, I believe, is approximately 800,000 versus 12,000 under the current law, moving to a 12,000 plus base. So proviso versus new law, that would be somewhere between 775,000 and 800,000 per my calculations, would be enough to, the deck chairs won't hurt anyone shifting them. But even our larger members understand that it's just not fair right now. And they have been benefiting from the fact that we've gone from 2.2 million to 4 million over the last 2 years.
And just finally, and when you look at that pie on slide 4, which is a minimal piece of or is only not even the 16%, but a minimal piece of what the bulk of the funding for our local health departments come from. It's just that the state money has more flexibility, so it can allow them to do more things that fit the needs of their community. Would that be correct?
Yes, that's correct. That's why we like the state formula so much. And our pursuit has only ever been to increase off of inflation and population changes, because if there's a desire to discuss, in our minds, if there's a desire to discuss a new direction, like a modernization effort of public health, I think that makes sense to have a conversation with the legislature about if you want us to do something different or new, and a new funding stream dedicated to that, those sort of conversations would make sense versus, personally, I would love to just have the state formula take everything in, but to us, it's just a fairness issue. We're just trying to catch it up from 1992. And we're over halfway there, but it's taken a little bit, of course.
Yeah, and I'm sure you've seen lots of things that other states are doing with their health departments that we possibly don't have the ability to do because if you're talking about looking at modernization.
Yeah, so like a case in point is Ohio, I believe. Their legislature chose to mandate local health departments become accredited through an accreditation process. Well, and they paid for it because they had to. How else could you do it? We would never be able to afford accreditation in most of the health departments in Kansas, even if they wanted to do it. It's just too expensive.
Thank you.
Senator Baumgartner.
Thank you, Madam Chair, and thank you so much for being here today, Dennis. I do have a couple of questions. First of all, how many of the 100 county members that you have, how many of them have a nursing home or an extended living home, assisted living, or hospice within their county? Do you know?
I do not. I can see about getting you that information, however. So you just want to know if it's in the county, not that they run it.
I doubt that they would run it, but I assume yes, in the counties.
Okay, I'll check. I think KDHE has because I think they have to be licensed. So I think I pulled the list once before. I see nods at the smart table. So does the smart table want to put that together, or is that a Dennis assignment?
That's a Dennis assignment.
Then Dennis will do it.
Yes. And the reason I ask is I would like us to go back, since we did. If you could show us that slide from your slide deck with regard to what the different responsibilities that your different local health departments, the services they're providing. Can we?
I think it's the second to last.
think it is. It's the second to the last, is it? Yeah. Because when I look at that, I see disease investigation. So only 91 of your 100 departments are working on that. And yet, when we were in the throes of COVID, that perhaps was the most important aspect. So I am quite curious. You work under KDHE, but what is your relationship, or at least the relationship of your local health departments with KDADs?
Thank you. In terms of KDADs, not as much that I'm aware of. Called as an association, I do not do a lot with KDADs. We had some conversations early in the pandemic, but otherwise not a whole lot there. I know they deal a lot more on the mental health side. I'm not sure. I can't speak to how often the individual local health departments work with them. My impression from them is very rarely. Most of the communications flow through KDHE. Including even with those cross discussions that we had early in the pandemic, most of the KDAD stuff, if you needed new stuff, we went to KDHE and said, we're having issues with something involving like adult care. What's going on? Is there a consistent message? That sort of thing. I do need to note this data is self-reported on the state formula, and there was so much turnover. Some of the individuals came in and did not choose the right options, because also I would think that would have been 100 in terms of disease investigation, quite frankly. Now, not on COVID. On COVID, because this was direct provided, KDHE started offering to health departments, and many of which took them up on the offer through the federal funding that we discussed earlier with Senator Steffen's question. They funded having the disease investigation housed through KDHE. Again, we're decentralized, so the health departments had to choose whether or not they were willing to turn over their investigations to KDHE. But once Delta variant hit, a lot of them did because it was so overwhelming.
I guess when I look at that, I see disease investigation as well as follow-up. And we know that the hot spots for the spread of COVID, at least particularly early on, was where there was this group living experience. And what we do know from KDADs is that they really did wait almost a year before the CDC mandated when training needed to occur in these assisted living or retirement homes, if you will, as far as prevention of the spread of disease. And it just seems like that was a tremendous missed opportunity for our local health departments to be able to go out, do that quick dip training. Because just as you've experienced turnover, they certainly have experienced turnover. Take us to the issue of when I look at that list, the one thing I don't see there is the issue that I see breastfeeding support, and so 90 of the 100 are providing that, but I don't see anything about prenatal or post-delivery services. And we know within the state of Kansas, our ranking is very low as far as, we have an unfortunate, a very high proportion of prenatal complications, deaths, as well as postnatal, post-delivery issues. And is that something that you see when you mention this notion of modernization for local health departments? Is that something that you see as an opportunity? If we're going to pull that percentage down as far as prenatal complications, the services of the local health department seem to me to be that most likely avenue. Is that something that you have considered or your local health departments have considered?
Thank you, Madam Chair. I'll have to say a maybe, because I don't know internally what each of them thinks of when they think about modernization. Now, the list that I provided you was truncated by me, so the reason why it's not on there is just randomly that I didn't put it on there. So I can tell you from the results, the pre and postnatal services are provided by 45 of the 100 on the self-reporting. So in terms of the other half that don't, or claim they don't, I could see it as an area where they could go into. Of course, modernization is a lot of times talking about things like foundational public health services, and the idea is having a staff that can be or I shouldn't say cross-trained, but trained on areas that then would apply across any sort of, I don't mean this in a negative way, but we kind of think of public health in silos. A lot of that's because of the federal funding. Like there's the MCH silo, and there's the immunization silo, and there's the health promotion silo. And, you know, we've often structured all of our thinking around everything is in a bucket. Like, no, I do WIC. That's my specialty. And it's like, and I do obesity training. That's my specialty. And now it's sort of like, well, there are relevant skills that if we got you those skills, then you'd be able to do pre and perinatal, you can do WIC, immunizations, all of it. All of these skills are applicable to any silo that is out there. That's what we normally talk about when we think modernization. So the idea is they would have the capabilities and capacity to then take on anything their community needs. And it would come down, if there's someone already doing pre and postnatal services in a county, one of the 10 essential services of public health, I think it's number 5, is access to care. But it doesn't mean the health department needs to think of itself as having to do every piece of care. If the private sector's doing it, for example, and everyone is accessing the resource, then there's no reason for the health department to intervene. They just need to make sure that that is always available, be another nonprofit or whatever. It's just about, because we'd never be able to do it all. It's just a question of if someone comes in and says, I need prenatal help on something, in the ideal world, the health department should be able to either say, we can help you, or here's exactly what you need to do to get help and connect you. Ideally, warm handoff. That's what we're hoping for. We don't expect the health departments to be able to do all the services themselves. It's too ambitious for as many departments as there are. Even with regionalized efforts, it would be a challenge, I think. But it depends.
Madam Chair, one last question. You indicated that Ohio had passed the law, I believe it was Ohio, for all of the local health departments to be certified?
Accreditation.
Accredited.
Yeah,
What's the price tag on that?
I thought it was 6 figures. KDHE might be, KDHE is accredited, as are some of our larger departments, so they can probably say more specifically. I have heard from the large local health departments that it's almost impossible, in their opinion, who have gone through accreditation, to accreditate without having at least one FTE dedicated solely to achieving accreditation, because there's also a lot of paperwork. Back before I was with CALD, but way early when accreditation was first introduced for health departments, this is around 2010 or so, I know that CALD as an association was looking at seeing, could rural health departments regionally work together, not in a consolidation, but regionally work together to do a single accreditation application. And I think ultimately it didn't save any money, and then the moment one person changed one protocol, everyone could fall out of accreditation, so it just didn't work, unfortunately.
Thank you, Madam Chair.
Thank you. And I have, the 2 quick questions that I had left were on that same slide. Just the definition of family planning, what exactly does that entail?
So family planning, if I remember correctly, I looked it up ahead of time and I didn't put it in my note slide. So birth control would be one item. It would also be for cancer screenings like cervical and breast cancer. So those, I think, are the 3 main areas that fall under the family planning services.
And preparedness?
Public health emergency preparedness, a lot of that is about getting ready for various disasters. It was originally back in 2003 or so, bioterrorism preparedness was the name of the program. It's been renamed since then because there's a lot more focus on like flood preparation, tornado preparation. So the public health role in preparedness is, of course, to drill with emergency managers and such to keep their skills honed. There are different focuses every year. It's a voluntary grant, but I think all but 1 or 2 counties are currently in the FEP program. And so they receive funding in order to participate with the Homeland Security Councils and to do all these drills and to have plans available to say like, okay, well, what happens if the county courthouse is destroyed by a tornado? What happens if your base of operations for managing an emergency is? And we've seen instances of that happen. So it's that sort of preparation.
Thank you. And committee, I'm going to try to end every day at 9:25. 1, to allow the chair to navigate the hallways to get to my 9:30 committee. But we have one last quick question from Senator Erickson.
Thank you, Madam Chair, and I will make it quick. Following up on a couple of things you've said, as it relates to family planning and women's health, you said earlier you can't be all things and provide all services to everybody. So do you make referrals in those areas, specifically to abortion clinics and to pregnancy crisis resource centers?
Thank you, Madam Chair. I'm not aware of any such referrals, but I don't work at the health departments. Health departments, as I think you all know, do not provide abortion services. It's not an area we're interested in being involved with. I've not heard a report of a health department referring anyone. I've never had a health department tell me, oh yeah, we refer people to abortion providers.
That, to your knowledge, that data isn't available, or if they do make referrals to pregnancy crisis resource, or that data is not available to your knowledge?
Not to my knowledge, no, ma'am.
Thank you, Madam Chair.
Thank you, committee, for your work today. Dennis, thank you for being here in committee. We are adjourned.